It's my pleasure today to introduce Dr. Egidio del Fabbro, who's a professor and palliative care endowed chair and program director of the palliative care service at the Virginia Commonwealth University. We hope to also be joined by Dr. Declan Walsh, who's the chair of the Department of Supportive Oncology at the Levine Cancer Center and Atrium Health in Charlotte, North Carolina. And they will be talking to us today on screening, diagnosis, and management of cancer cachexia in the supportive care clinic, best choices for daily clinical care, and talk to us about how we treat patients with cancer cachexia presently. And so, Egidio, I'll let you take it away.
Yeah, thank you, Richard. I really appreciate the invitation, and I'm hoping I'm going to get some feedback to help me refine my overall template or a framework for a cachexia clinic, because the idea was that it would be pragmatic and would not only be a specialized clinic, but perhaps could be introduced in other supportive oncology clinics. And as you'll see, where we implemented the framework with varying degrees of success. So the way I thought I'd start this is, provide the overall framework. So this was a suggestion in 2015 of perhaps the necessary steps in establishing a cachexia clinic, a nutrition in cancer clinic, a malnutrition clinic. I think words and names are important. And I'm not sure anybody's settled on a term for this. Cachexia clinic is a little cumbersome, I acknowledge, and a little difficult to explain to our colleagues and our patients. So obviously the goals are to identify patients at risk, patients earlier on, maybe to identify them in that pre-cachexia phase, incorporate a multidisciplinary approach, and we already had that in our supportive care clinic. Being a palliative care clinic, we had a psychologist, a social worker, as well as a nurse, of course. And then the assessment tools, we suggested a few that might be considered. As you note there's no screening tool that we suggested or recommended. And this was in part because we didn't anticipate we would be able to cope, or we didn't actually know what to do with patients who would be screening positive. We thought we didn't have the capacity, didn't have the support, but that is an obvious gap as you look at that list, at that framework. And then the multidisciplinary management, I guess this will differ by institution. And at the time, we were fortunate to have physician, dietitian, physical therapist, psychologist, and nurse. And then a suggestion of monitoring the key outcomes: weight change, appetite, fatigue, physical performance, and body composition, and perhaps how best to do that in an efficient, pragmatic, and fairly brief manner. And throughout this, choosing the assessments, choosing the outcome measures, choosing perhaps management or the interdisciplinary team, we had to be aware of making the case to our oncology colleagues, and also to make a case to the institution for the support necessary for such a clinic, namely the personnel, mainly the physical therapist, which is fairly unusual, but also the dietitian. In our institution, we have, I believe now, 3 dietitians. At the time, we had 1. So all of those complications, increasing the complications and decreasing the ability to complete cycles of chemotherapy, obviously critical to both patients as well as oncologists. We made the case that perhaps we'd be able to improve this cluster of cachexia and fatigue. And as we know, there are no effective medications for fatigue. And of course, at least in the United States, medication is yet to be approved for cachexia. And then we also made a case that we might improve performance status and hence, again, be able to enroll more patients in clinical trials, maybe in early phase trials. Also pointed out the time constraints that oncologists have and that they couldn't possibly focus on nutrition as well as all the nutrition impact factors and assessments. And then, you know, some institutions, academic centers might be interested in the research opportunities. So I'll describe the evolution of how we chose our outcomes and metrics. And initially, we started the cachexia clinic at MD Anderson in about 2008 with a few resources and personnel. And then I'll go through some of the loftier ambitions that may or may not have come to fruition later on at VCU. So our initial thought was to be fairly pragmatic. We saw many patients, obviously, with advanced cancer. We were a supportive care clinic staffed by palliative care physicians, and we would often encounter patients with tremendous weight loss who were obviously cachectic. And still at the time, as is now, there's no FDA-approved drugs. So our thought was to focus on those potentially reversible factors. So a very pragmatic initial approach to patients. And especially because we were used to and we thought fairly skilled at managing symptoms, we focused on the nutritional impact symptoms that you'll see in green: the depression, anxiety, nausea, severe pain. You can imagine patients with mucositis wouldn't be able to eat or take insufficient calories. Drowsiness, we also found, was often a problem. Those were the days when patients were prescribed large doses of opioids. These days, the pendulum is perhaps swung over to the other side. But in essence, we often deprescribe because patients were too drowsy to be able to eat. And then there were a number of other conditions: obstruction, constipation due to opioids, due to ondansetron. Again, sometimes deprescribing, sometimes switching medications. We also thought that there were a number of disorders associated with muscle wasting. Some we could do nothing about, we felt, including aging, but at least we would be able to identify patients at higher risk. And then there were a host of other potential abnormalities or deficits that we thought we might be able to address, including vitamin D deficiency, thought perhaps insulin resistance, because of the paper by Luntone that came out at the time showing that the addition of low-dose insulin to patients with cachexia prolonged survival, although it didn't improve any other outcomes. And then we'd always been interested in hypogonadism, low testosterone, and we thought at the very least it might be affecting or increasing the risk of fatigue, thyroid dysfunction, corticosteroids. So we thought we could modify some of those aspects. Again, not cachexia itself and the catabolic activity, but at least address some of these comorbidities or cofactors. At the time, we termed them secondary cachexia factors. And so, you know, there are these whole host of outcomes and which to choose, what might be most important, and also what might we be able to reverse amongst that large list. So we felt that initially, as I mentioned, nutritional impact symptoms were the low-hanging fruit, and every single patient in our supportive care clinic underwent assessment with the Edmonton Symptom Assessment Scale. And so this is very useful in that it identifies a number of nutritional impact symptoms. The other advantage is that it has a numerical scale, so 0 to 10. And of course, implementation of this ESAS in institutions or provinces has resulted in improved outcomes. As an example, in Ontario, implementation of the ESAS resulted in fewer emergency room admits. So there was a lot of literature and evidence that this might be useful, and we thought it would be readily available, obviously, in our clinic. And in addition to the ESAS, we did feel that a PGSGA was necessary. So this is endorsed by the American Dietetic Association and had some outcome measures that are not in the ESAS. You'll notice constipation, also feeling full quickly. Nausea is in the ESAS, but not this feeling of the early satiety, bloating. And as we know in advanced cancer, based on fairly small studies, I have to acknowledge, there seems to be autonomic dysfunction and gastroparesis. And of course, this PGSGA has been shown to correlate with outcomes, including survival. So the other issue that we had was percentage weight loss for inclusion of patients. At the time, we used 5%, and it was based on the consensus criteria. We did also note that patients with a lower BMI might ill afford to lose 2%. And as it turns out, this is all this was fairly accurate, a fairly accurate prediction, because this is a large study from Vicky Barakos, and based on BMI and percentage weight loss, they were able to predict survival of anything ranging, as you can see, 20.9 months for a patient with a grade 0 to 4.3 months for a patient with grade 4. So, patients obviously have just had 2.5% weight loss and have a BMI of 20 are equally at risk as somebody who has a weight loss of 11% and a BMI of 25. So we've got this little diagram up on our clinic, and we make note, obviously, of percentage weight loss and also baseline BMI. And so this grading system was found to be useful for prognosis independent of cancer site stage or performance status. Right, and then as far as interventions concerned, at the time there was an acceptance that perhaps we didn't have good pharmacological measures. We'll go through briefly with Megestrol and corticosteroids. We felt that most of the intervention would be relying on exercise, nutrition counseling, and a nutrition impact symptoms that I'd gone over previously. But at least this multimodality, this provides a framework for perhaps a multimodality approach to patients pharmacologically, that we might be able to target inflammatory cytokines. At the time, there were several studies showing the benefit of celecoxib, also ibuprofen, but we felt that obviously there was, that the evidence wasn't strong enough, and there was significant risk to many of our patients who were over the age of 65, had a risk for GI bleeds. And then elevated resting energy expenditure, the use of beta blockers, again, it being used by some centers in Sweden, but we didn't have a good way to measure resting energy expenditure. We had the handheld indirect calorimeter, which is very inaccurate, and been perhaps more attractive if we'd had a metabolic cart or a metabolic chamber use of things like, to use interventions like beta blockers. And endocrine dysfunction we were obviously interested in. So, the MEGACE at the time obviously was associated with positive outcomes, appetite, weight gain, and 30% and 50%, improved quality of life, but significant negative outcomes, including increased risk of death, thromboembolism, and with prolonged use, hypogonadism to castration levels. So there were several negative outcomes, and we didn't think that it was a good idea to employ the Megestrol. The same with dexamethasone, except for the end of life. This was a 2-week study published in JCO. There was another trial also published in JCO by the Norwegian group using an equivalent dose of methylprednisolone, about 3 milligrams Q12. This was for Q12, and they showed improved fatigue and improved appetite rapidly within the first week. The trouble with the dexamethasone as an intervention is, what to do after week 2, right? We don't know whether we should be tapering, giving patients drug holidays, and the longer you use this, the more likely there is myopathy developing and infections. So what did we find when we started our cachexia clinic and we looked at the first I think these were 160 odd patients. So a little surprising was a low median BMI. I'm not sure 10 years later with the obesity epidemic whether this might change. So maybe not too many patients with sarcopenic obesity. And you can see based on the ESAS, the symptom severity that was highest or greatest was appetite loss along with fatigue. And what did we do? We addressed the nutritional impact symptoms. And here, perhaps, again, I illustrate the PGSGA that identifies early fullness, early satiety, this bloating related to gastroparesis. We used a lot of metoclopramide. And metoclopramide, I still believe, is a useful drug. We have small studies showing it's effective in gastroparesis and is still the drug of choice in non-CINV related nausea and vomiting in patients with cancer. We also used a lot of laxatives in our patients who were mostly on opioids. And I have to also note that many of these patients were referred by palliative medicine colleagues, so sort of self-referrals. And in depressed mood with mirtazapine, and this is based on mirtazapine being most prone to cause weight gain of all antidepressants. And what did we find? That the median number of nutritional impact symptoms was 3. The higher the number of nutritional impact symptoms, the greater the weight loss, poor appetite. And with our interventions, which were focused mainly on nutritional impact symptoms, we did improve appetite scores from 7 to 5. And more than a third of patients gained weight. And I have to point out that these were patients all with advanced cancer and maybe regarded as refractory. And at no, on, I don't corticosteroids, right? And this is just a review of the pharmacological management, and there's obviously more interest in olanzapine, especially because olanzapine is useful for CINV as well for non-CINV. And then taste supplementation. We did put patients on, or zinc supplementation rather, for patients who had taste alterations. And then what about metabolic assessments or labs? We did a few labs, vitamin D, C-reactive protein, and testosterone. We did do indirect calorimetry and abandoned it after a while because of the inaccurate results. We found patients with elevated CRP in at least in male patients. This shows patients who were seen in the cachexia clinic had a high CRP, had obviously poor prognosis. And this has been established and reported many, many times before us. However, when we had a low testosterone and a low CRP, this resulted in the even poorer prognosis than either hypogonadism alone or elevated CRP alone. So we had about 3/4 of our males with low testosterone. At the time, we didn't report low vitamin D, but this was a subsequent paper, and no surprise, we found low vitamin D, particularly in patients who are non-white and female. So did we do any body composition evaluation? No. We tried to do a mid-arm muscle area and bioimpedance, and subsequently, I know MD Anderson Cachexia Clinic is doing bioimpedance on all patients. Mid-arm muscle area, I think, is simple to do, but it's a little time-consuming and has actually been used as an outcome measure in a trial of GI cancer and cachexia. Nutritional counseling was received by all patients. Mainly, we recommended frequent small meals that were calorie and protein dense. I don't think we were recommending any of, and so that's in red. All the ones in black, we weren't really recommending at that time, especially the protein goal. I don't think our dietitian was recommending any particular goal. And of course, this is a fairly recent recommendation by ESPEN. And we didn't do any physical assessments at the time. We tried to implement this, as I'll show in 2 case studies of patients, a short physical performance battery, But we had a physical therapist who would be able to do the physical performance battery. It's a little, I take much longer than she does. She takes between 4 and 5 minutes, 6-minute walk, which I'm not advocating necessarily. And certainly we haven't been consistent in implementing a 6-minute walk. And are probably going to abandon it as a pragmatic outcome measure. And then hand grip strength. I had rationale for the short physical performance battery. I know I'm eager to hear Richard's thoughts on it because I know he's been focused on this. We thought that because it was associated with health utilization and outcomes that it was worthwhile doing, and there was some literature to suggest that particularly in patients with cancer also it might be useful. And our physical therapist was present in the clinic to recommend an exercise program. So I'll just give 2 examples at VCU. We had a 55-year-old male with head and neck cancer, underwent cisplatin and XRT, and then he was referred not only for cachexia, but also for pain, had been on oxycodone and had lost 17% of his weight within the past 3 months. And that, you can see his ESAS scores on the right, higher number is worse. So BMI 15, pretty low. 8 weeks later, what did we do? We rotated his opioid to methadone, thought we'd be able to provide better management of his pain, but it also is a better drug for neuropathic pain. Started him on metoclopramide for nausea, but also presumed gastroparesis, and duloxetine would help again, his neuropathic pain as well as depression, and we replaced his testosterone. And there you can see improved numbers as far as BMI is concerned, short physical performance battery. And so just one more patient I want to give us opportunity to have a discussion and questions at the end. A 57-year-old female who was also referred to us, and unfortunately referred to as a very advanced disease, peritoneal carcinomatosis, and weight loss of 22%, complained of constipation. You can see compared to the scores, appetite was 4 out of 10, so appetite wasn't a significant issue. We managed her with fairly few medications, mainly laxatives, and we believe it improved constipation, improved some of the nausea, perhaps the early satiety, and again you can see improved outcomes related to the short physical performance battery and BMI. So just to finish off, this is a reminder of our approach. I have to emphasize that there are gaps here, many gaps, not just a single gap, mainly I think with screening, obviously, and again, whether we chose pragmatic assessments, I'm not sure. I think we tried to do a more detailed evaluation at VCU with some of those physical performance measures, and I think they are possible. I think, however, it would be essential to have a really skilled support staff and maybe to be able to include a physical therapist as well as a dietitian. So end things there. And if Declan's available, maybe we should have Dr. Walsh begin. Otherwise, I can take questions.
I don't see his name.
Let me see.
Thank you for,
sorry, they say it's been locked out of the meeting. Can someone send him the link?
Yeah, Aaron, can you resend Dr. Walsh the link?
And I don't know if you have Angela Jenkins, his assistant. Maybe you can copy her. Yeah, thanks.
Thanks as always for a great talk. You had brought up the physical assessments and kind of my thoughts on that. The short physical performance battery, I think, is a good measure of physical performance. I think it really depends on what, the individual patient, what the goal is, what you're trying to assess. Is this a clinical trial? What stage of the cancer cachexia continuum is the patient on? My experience with that short physical performance battery is for patients who are either pre-cachectic or early cachexia, who may not be older or pre-frail, that the short physical performance battery, they may be, near perfect score. And there's a ceiling effect with an assessment that has a score of 0 to 12. So I didn't like it as a great measurement for a clinical trial where we're trying to enroll patients early. But I think for patients who are referred to a cachexia clinic, where I would imagine they're referred kind of later on the cachexia spectrum, either by palliative care or by oncology, I do think it's a great assessment. It measures cardiopulmonary, neurologic, physical performance, balance. And so for patients who might be towards the middle or towards the other side of the spectrum, I think it is a good measurement for practical use in a supportive care clinic.
Yeah, and I think you're absolutely right that, because we were by nature a supportive care clinic staffed by palliative care physicians, and then the specialist cachexia clinic one day of the week, I think by nature we were getting patients with advanced cancer. And I think that may be the reason why our short physical performance battery were often, and this is anecdotal evidence, because what I should have really is a retrospective at the very least of all our patients seen, but fairly often, and this was surprising also to the physical therapist, who initially thought that we would be getting 11 out of 12, 12 out of 12 scores, and we wouldn't be often getting scores of 9 out of 12 or below, which is associated with a poor outcome. But it was unusual. The other thought we had, of course, is that your patients in Rochester might be hard here, and it might be all the snow and the physical activity.
No, we actually have an older Rochester has an older population, which is why geriatrics is such a strength in the area. But I think it depends on if you're looking for assessments for clinical trials and interventions versus the practical assessment in the cachexia clinic, which is what you're doing. And so I think there are two different ways to think about the assessments. And it may be different than what we use for clinical trials for, let's say, an exercise intervention versus what we're doing to screen patients on whether they should be referred to a clinic such as this.
Right. So it may be, and I don't know what others think or you think, but it may be that hand grip is a pragmatic, reasonable choice. I think if you have a physical therapist, they really are very efficient at doing the short physical performance battery and can do it in less than 5 minutes. I've timed her. She does it in 4 minutes, 15 seconds. So,
I wanted to ask you about the physical therapist, but I see Angela Jenkins on. Is that
that's Dr. Walsh.
Okay, so I'm gonna Aaron, could we we'll unmute? There you go. And Dr. Walsh, if you're there.
Yeah, Declan, hi, how are you?
Hi, how are you?
Yeah, apologies. We got trapped in Zoom hell there.
It happens.
Yeah, and
thanks for joining.
We're now in Zoom heaven, so I guess that's okay. So,
did you have slides you wanted to share? We could have Egidio stop sharing his screen.
Sure.
It should have stopped sharing.
Yeah, you're good.
Yeah.
Can you see my slides now?
Yes.
Yes, we can.
Okay, very good. Well, thank you. I realize we're well into our time here, so I'll sort of just hit some of the points I wanted to make. So just to summarize, I suppose, first of all, in Charlotte, we've been in the process of constructing a new department of supportive oncology over the last few years, and one of the exciting things about that has been the creation of the department, a number of sections, but including a section of oncology nutrition. And so that's been a wonderful initiative on the part of the Cancer Institute to dedicate time and resources and so on to this activity. And so we're developing clinical services and research activities in that area, and linking that with other areas within the department, such as cancer rehabilitation and some of the other things I'm sure you've already talked about earlier. One of the points I wanted to make today is that a lot of the work that's been done over the years in research around malnutrition and cachexia and so on in cancer patients has tended to be in patients with advanced disease. And one of the basic points I want to make today is that many of these problems and abnormalities are evident at diagnosis. The first day that a cancer patient sees an oncologist. And the members of this society, I'm sure, know well that this simply does not receive these abnormalities, these problems, these challenges do not receive the attention that they deserve because of they should, and because of the enormous impact that these issues have on the natural history of the cancer process. And one of the really second points I want to make is that this is a great shame, because these abnormalities are telling us something about the natural history of cancer in general and specific cancers as well. And if we can learn more about these issues, then we can also learn more about how to better manage the cancers. So it's really a lost opportunity from a humanitarian and from a clinical, as well as from simply a tumor management perspective. I've had an interest in this area for a long time, although it's not something that I've, if you like, specialized in. And it's actually, I'm a senior in my career, shall we say. It's nearly 40 years since I first published something about taste changes in cancer patients. That was an incidental observation in a study that I was involved with at the time when I was working in the UK. But I'll show you in a moment that I've kept up that interest, and we'll move on to some of these issues now. So one study that came up was, and which has interested me and still interests me, is what is the role of the dietitian in this whole area? And the lack of clarity about the role of the dietitian and their interactions with the physicians and the other members of the clinical team. And this was a publication basically which came out of just observing our dietitians in an acute care palliative medicine unit at the Cleveland Clinic. And, the malnutrition was highly prevalent in that setting, but even our physician specialists, our specialists in palliative medicine, were under-recognizing, under-diagnosing malnutrition in that setting. And the coordination with the dietitians was really not what it should be. And, if we couldn't get our arms around it in that setting, what hope is there for anybody else? And so we really realized that we were not doing what we thought we should be doing. And then another study, again, looking at the role of the dietitian, was around, were the patients getting referred at an appropriate time to the dietitians? And in this particular setting, and this was work that was done in Dublin when I was there setting up a palliative medicine chair there, was that patients were being referred at a late in the illness to the dietitian, when the problems of malnutrition were already well established, far advanced, and that if you asked the dietitians, were these patients being referred on time? In the majority of the cases, the dietitians were saying quite clearly that the patients should have been referred weeks and indeed months before they actually were referred to them. And this raises the issue then of what are appropriate screening techniques and when should those be done, and what actions should be taken as a result of those screening techniques. So the whole issue of the role of the dietitian, I think, is really something that requires lots more work, lots more attention. And just to parenthetically just say, within the United States, in cancer centers, many cancer centers and patients who are getting their routine cancer care have very limited access to dietitian colleagues. And that's something that also needs to be addressed, the availability of dietitians to see patients in a timely and effective fashion. We decided in that setting, we formed a small dietitian research group. And this was a group of dietitians who were working in various cancer centers in Dublin. And we first of all did a review paper about taste and smell changes in cancer patients, and then went on to do a series of small studies looking at these issues. We wanted to do something that was cheap and cheerful. We didn't have a lot of resources, and so we thought this would be something that we could maybe make some impact on. And the first study basically looked at self-reported taste and smell changes in patients with solid tumors at diagnosis. And over 2/3 of the patients presenting to a radiation oncology center for their first visit had various multiple and complex taste and smell abnormalities that were evident if you actually asked the patient the specific questions. And again, one of the issues here is, how do we best evaluate these symptoms? Because people will often not volunteer them. And so they need to be sought out and investigated aggressively by the clinicians involved in their care. And this is certainly one set of symptoms that doesn't receive a lot of attention in routine cancer practice, or indeed even in more specialized areas like palliative medicine, doesn't get a lot of attention. We then went on to having sort of identified that, we then revisited the issue of, were these taste and smell changes due to the radiation or chemotherapy that the patients were getting, and interviewed a group of patients who had never had radiation therapy or chemotherapy. And despite that, these taste and smell changes were very common and complex, as I mentioned earlier. We then went on to add objective measures of both taste and smell to the subjective evaluations. And the message really out of this work was that there was a poor correlation between the subjective and the objective abnormalities, although the objective evaluations did appear to add some specificity to the clinical profile, but we weren't able to pursue this any further, and were then obviously very intrigued when the whole COVID thing arose, with the taste and smell abnormalities being part of the early diagnostic profile of patients affected by COVID, because one of the things that we were wondering about at that time was, why do people who develop cancer and before they have any chemotherapy or radiation therapy develop these taste and smell changes, suggesting some form of central nervous system abnormalities or other changes that may reflect the complexity of this patient experience, and in turn, of course, affects the types of food that people will eat, the types of foods they like to eat, and their overall enjoyment of food. One other area that we investigated at the time, swallowing difficulties, which are poorly defined. affect somewhere between 25 and 40% of patients with advanced cancer, with metastatic cancer. And so we decided to do a study. This was a PhD a student conducted their PhD looking at swallowing abnormalities in patients who had no anatomical reason to have dysphagia. So these are patients who had tumors outside the head, neck, and the upper gastrointestinal tract, and found that a significant proportion of patients had, when you look closely, did indeed report trouble or had objective evidence of swallowing difficulties. About 25% of the patients had these problems, and that's another important and unexplained issue. One thing I would just say, it's frequently associated with other upper aerodigestive symptoms, such as hoarseness, nausea, and cough. And so but the mechanism of this is still very unclear. I'd like to just switch then to a series of studies that we conducted on a couple of large data sets. And this was one dealing with patients who at diagnosis had stable weight, who gained weight, or who lost weight at diagnosis, as compared to a time frame in excess of 6 weeks, 6 weeks later. And those who had weight loss obviously did very poorly, and that's been well reported. But patients who gained weight did much better over time than the weight losing group. So very big difference in the overall survival of patients who gained weight. And we tend to focus on the weight loss, but weight gain appears to be protective. Now, we didn't know from the study why people gained weight. It could be because they responded to treatment. It could be that they got some intervention, nutritional or otherwise. But it is something I think we need to pay more attention to, not just to look at the people who lost weight, but what about the people who did not lose weight or who actually gained weight? What happens to them? And I think that's something that should receive more attention. In the same study, we looked at BMI, and just to make the point, in this setting again, obviously the mortality is increasing as time goes by. But if you look at the red line here, this is the group who by BMI are diagnosed as being obese. And this is at diagnosis, at T1. And obesity is in fact protective here in this particular setting. And this is in a group of the initial group. You can see we're talking about nearly 2,000 patients here in this group. So we feel that these observations have some merit, and that this issue around obesity and indeed of hypertension, which I'll come to in a moment, having some protective influence in patients. And again, these are all patients with solid tumors. One of the things a number of people have been interested in is around the concept of autonomic neuropathy and autonomic failure as being a component of the, quotes, anorexia cachexia syndrome. And as part of the study I just showed you, looking at where we looked at BMI, we also looked at pulse rate, which is the RHR here, resting heart rate, and blood pressure in patients, because all of this information is collected routinely. And again, this is in a very large data set, over 5,000 patients. So this is at T2, and patients who had a high resting heart rate, a tachycardia, defined as being a resting heart rate over 100 beats per minute, had a much worse prognosis than patients who had a normal or indeed a slow resting heart rate. And a frequent observation in patients with advanced cancer is that they have a low blood pressure and a high pulse rate. And it's something that has never really been well explained. But we have an emerging area now within supportive oncology of, quote, cardio-oncology. And these issues around cardiovascular abnormalities as part of this overall mystery of the anorexic cachexia syndrome as in a very important issue. And this is data that has been submitted for publication. To give you just some, and this is from the same data set, just to give you some idea of the impact that these abnormalities have. Obviously, if you have if you're underweight and again, at around the time of diagnosis, you do poorly. The hazard ratio here in terms of your overall survival, so you have a high chance of an early death. If you're overweight or obese, however, it appears to be protective, as I said earlier on. And then if you look at systolic blood pressure, as your blood pressure goes up, the hazard ratio for early mortality goes down. And it's a consistent pattern with each cohort of increment in blood pressure. And the reverse of that, if you like, with heart rate, is that if you have a low heart rate, you still have a risk of early death. But as your heart rate, your resting heart rate is higher, it escalates dramatically. And as I said, this is an early stage disease. This is not in advanced disease or in a palliative care situation. This is pretty close to the time of diagnosis, or actually at diagnosis and pre-treatment. I mentioned the issue of screening earlier on, and the use of, what's the best screening tool. We've done some work on that recently using MST. And this is just to make the point that if you look at upper GI, lower GI, and thoracic tumors, they have a sort of a consistent pattern where there is about 40% of patients, again, this is at diagnosis, about 40% of patients are at high risk of malnutrition based on their MST scores. But if you look at something like breast cancer, it's a very different pattern. And we tend to lump all these tumors together. And I think that's a mistake, because breast cancer is an outlier in many ways in terms of the natural history of breast cancer and its implications for malnutrition. But it's also to make the point that at diagnosis, many patients, the day they walk in the door, the first time to see a cancer specialist, they're already at significant nutritional risk, and it's not getting the time and attention that it deserves. And this is just another study looking again, it's part of the same data set, and looking at the, if you like, the confluence between a dietitian evaluation of malnutrition and the physicians. And when the physicians pay attention to this, there's a high degree of congruence between their evaluation of malnutrition, whether it's present or absent, and the dietitian. But the physicians tend to pay much less attention to this. And this is something that, again, I think is something that really we need to have urgent attention to in oncology training and in day-to-day oncology practice. And then just to make a last point, this is a paper we published, I guess, a couple of years ago now, and really about what advice do cancer patients get? And the answer is that we looked at 9 English speaking countries, their National Cancer Organization websites. And if you look at the actual content of the website, if you're a patient and you go to say, well, gee, what should I be eating or not eating, as the case may be, the general advice in there is pretty good. But if you're not tech savvy, if you're not sophisticated medically, the advice is much less helpful. And there's frequently, language such as eat a normal diet. Well, what is a normal diet? If you're a 18-year-old or a 30-year-old truck driver who left school early, that's really not very helpful advice. And so that circles back, I think, to the role of the dietitian and this whole issue around what is it that cancer patients should be eating? Is there a diet that can be recommended? And not assuming that that patients or their families are sophisticated in this regard. And these websites, all of them, while many of them were, made, we thought, very good attempts to do this, they weren't as user-friendly as they should be. And remember, we were the people who were interested in the field, nurses, physicians, and others who were conducting this work. And if we couldn't use the websites well, what chance is there for the average patient who has little knowledge or insight into this area? So to sum up, I guess my points would be that many cancer patients, the day they walk in the door to see a physician, are already in big nutritional trouble. And so we need to get out ahead of that. The issues of smell and taste changes in BMI, in weight, are all things that all this information is out there. And there's an opportunity to do some really big database type studies to further investigate some of these issues. And it appears that some of the conventionally collected vital signs are helpful to us in prognosticating in this situation and better understanding perhaps the pathophysiology of the anorexia cachexia syndrome. And then I think we need to really do something much more aggressive about how we advise patients and their loved ones about their diet and make it more real world for the average person, get out of our ivory towers in that regard. And I think the cancer societies need to lead in that regard. So thanks for the opportunity to present today.
Thank you both for those very informative talks about how we care for patients with cachexia, how we assess them, and picking up on Dr. Walsh's last comment, there was a question, and please enter your questions into the chat, but there was a question from Dennis Guttridge asking how we as clinicians teach patients and families and caregivers what cachexia is, and goes to your point, are there user-friendly literature websites that we could use to educate? As you pointed out in your last study, a lot of these resources we provide are not in depth enough to give people the information they need. So how do you educate your patients in your clinic, whether they're supportive care or cachexia clinic, what cachexia is, and are there resources that you point them to other than, having them meet with a dietitian? And that could be Dr. Walsh or Dr. Del Fabbro.
Egidio, you'd like to comment on that?
I'll hand that over to Dr. Walsh. I absolutely agree with everything that's been said regarding the nutrition and the lack of detailed information. And we try to keep it simple and recommend protein and calories, but mainly harp on the protein. And it's amazing how often patients are taking insufficient calories and particularly protein. And there's a study also from McGill that suggests 80% of patients with cancer are not taking enough calories are not taking sufficient calories for a patient who is otherwise well. So you can imagine if they are hypermetabolic, needing and getting chemotherapy or post-surgery, that they need even more calories. But I'll hand that to Dr. Walsh because it's a complex and difficult answer.
Yeah, I think that what we've decided to do is to try and go above the problem. What I mean by that is that we have a screening process which includes the MST, and that's some of that data I showed you, which is completed by patients on an iPad when they walk in the door. And we have data now on about 28,000 patients who've completed this. And so basically, if they hit a high score on the MST, we have now put in place an automatic referral to the dietitian. And that's not sufficient, but at least I think it's a start. And I'm a medical oncologist by background, and I fully recognize that for the oncologist who's seeing a patient for the first time, that with all of the issues that they're trying to address, taking care of some of these other issues is really difficult. And unfortunately, at least in the United States, the pressures on people's time now to see patients in 20 minutes or 40 minutes, I mean, it's just absurd. And that's really one of the sad deteriorations in medical care in my lifetime. And so, the oncologist is forced to drill down on certain issues and is unable in the time available very often to assess the full complexity of the cancer experience, whether it be nutritional or other issues. And so I think we need some triggering mechanisms to get our nutritional colleagues or psychologists or others, as appropriate, into the process that to some extent are done alongside what the physician is doing, but in a sense not waiting for the physician to recognize that there's a problem. If there's a simple screening mechanism that is reliable and can trigger a coordinated approach to the management of the nutrition, as it would be in this case.
As we have about a minute left or so, a question by Dr. Rishi Jain, a question I had as well, is setting up these supportive care clinics or cachexia clinics, as you will. The barriers to reimbursement for someone like a physical therapist or a dietitian. How have you addressed these challenges for reimbursement for those types of services?
Right. I mean, this is the money driving the clinical practice, when the clinical practice should be driving the money, right? So what we've done, we are setting up a quote metabolic clinic. I think the mistake that people make in those clinics, and we've made that mistake, so is trying to have everybody in the clinic at the same time. So that's one issue. So having an interdisciplinary team review of the patients and saying this patient needs to see a dietitian, this patient needs to see a physician, avoids some of that. It doesn't eliminate it entirely, but it makes it a much more efficient process. And we found that so far to be effective. And provided we document, and we can document, the extensive clinical abnormalities that we've been talking about today, I think you can justify a physician visit or a dietitian or a therapist as appropriate. But
it's almost like a tumor board for cachexia almost.
Exactly.
That's interesting.
We're using that mechanism in prehabilitation clinic and in some other areas as well for the very same reason. And
people who have to jump off over the last couple of minutes, that's quite okay. There's two more questions. One is the use of bioelectrical impedance as a way to measure body mass by Dr. Actis. My experience, and it's in the literature, is that it may not be as accurate as things like CT scan and DEXA, but it's not any additional radiation exposure. It is probably cheaper than these modalities, but having in the oncology clinic the use of the CT scans and the availability seems to make the most practical sense. But I don't know what Dr. Del Fabbro, your experience has been with using that in the clinic.
I mean, just briefly, you're right, it's not that accurate, but longitudinally it does provide a reasonable assessment of change. And just as an example, the new Pfizer's GDF15 monoclonal antibody, they are going to use one of the outcome measures. Secondary, of course, they're going to be using bioimpedance, and because it's convenience and practical.
Got it. And this is a question. The last question from Dennis Guttridge asks, and this is actually a question I had, is as in palliative care fellowships, what sort of education on cachexia is occurring? What sort of training are our fellows, whether they're in oncology or in palliative care, what sort of education on cachexia are they receiving?
Well, I can speak to the medical oncology area. Of them in the medical oncology exams, about 11% of the content has to do with supportive care, and none of it includes nutrition that I'm aware of in any form.
That was my experience in oncology fellowship as well. I started getting an interest during my fellowship, and I was doing it all on my own during my fellowship training. There wasn't any formal right. training in oncology fellowship. Maybe Dr. Del Fabbro could talk about palliative care fellowship.
Again, I think it's similar. You know, I believe, as I recall, we had 2 questions. So this is anecdotal. I haven't studied this, but as I recall, 2 questions were on nutritional cachexia in the palliative medicine boards that I took. And again, I disagreed with all 4 answers, by the way.
Well, I want to thank you both for great talks and a great discussion, and thanks for everyone for sticking a few minutes extra due to our technical difficulties earlier. Again, want to put in a plug for our annual Cancer Cachexia Society conference, which will be in August in Gainesville, Florida. It will be a hybrid model, and I believe there'll be a call for abstracts soon, but you can see the website cancercachexiasociety.org. Stay tuned for that. And we have upcoming seminar next month in July. I think we'll be with Dr. Andrew Hendafar, who will be talking about interventions for cachexia, and you will all be receiving email notices about that, as you have been for these seminars. So I want to thank you all for joining us, and everybody have a great week.
Thanks for the opportunity to be here.
Take care.
Bye-bye.
Thank you. Bye-bye.